Hello everyone, welcome to my YouTube channel. This is Sir Steven, and today we will talk about chronic inflammation as a part of your medical histology and pathology laboratory. Inflammation is a part of your body's defense mechanism. It is the process by which the immune system recognizes and removes harmful and foreign stimuli and begins the healing process. Last time we discussed about acute inflammation, but for this series, this will talk about chronic inflammation. We also refer this to as the slow, long-term inflammation, which lasts for prolonged periods of several months to years. Generally, the extent and the effects of a chronic inflammation vary with the cause of the injury and the ability of your body to repair and overcome the damage. The course of your disease might include repeated acute phases, let's say when your tissue damage is predominant, and intervening chronic phases when chronic inflammations molders along with the ongoing tissue repair. So these are the outcome of your non-specific chronic inflammation depends on whether local and systemic factors favor the injurious agent or the process of healing. In this table 4.1, these are the factors that affect the healing. Chronic inflammation usually heals by fibrosis, and it will be tabulated what are the factors that impair resolution and healing and the factors that aid resolution and healing. These are the cells in your chronic inflammation in high power. In this figure, you will see the plasma cells in P are identified by their amphophilic or their purple cytoplasm and eccentric clock face nuclei. The plasma cells here are differentiated B lymphocytes that are committed to antibody production. Your lymphocytes in L are seen as dark rounded nuclei with a thin, almost invisible rim of basophilic cytoplasm. These are the effector cells of the specific immune response and include both the helper and cytotoxic T cells as well as your B cells. Macrophage in MA are recognized by their oval or kidney bean-shaped nuclei and pale cytoplasm. Eosinophils in E have bilobed nuclei and brightly eosinophilic granules in their cytoplasm. When stimulated, these eosinophils release their granule contents, including major basic protein, a substance that is effective in killing parasites. Some neutrophils and many active fibroblasts are also commonly found in your chronic inflammation. This is chronic peptic ulcer. In this image, you will see an entire ulcer. These labels are E for your eosinophil, F for fibrous granulation tissue, Fi fibroblast, L lymphocyte, M muscular wall, Ma macrophage, P plasma cells, SC the scar, SL the necrotic slough, V is the vascular granulation tissue. Your chronic peptic ulcer reflects this dynamic balance between tissue destruction and repair. A section in this chronic ulcer shown in this image has an ulcerated surface which is covered in slough and composed of a pink staining layer of necrotic debris combined with the fibrin and neutrophils of an acute inflammatory exudate. Beneath the slough is a zone of vascular granulation tissue in V. These are the features seen from the previous slide at a higher magnification. The next layer is a zone of fibrous granulation tissue in F. As seen in detail in letter C, deeper still in the ulcer base is a fibrous scar in SC. In this deep ulcer, the muscular wall M is completely replaced by the ulcer crater, the granulation tissue, and the scar. If a large blood vessel is present in the ulcer base, erosion into the vessel leads to bleeding into the stomach, giving rise to hematemesis, or we call it vomiting blood, or melaina, black tar-like feces composed of altered blood. This micrograph is showing you a disease called bronchiectasis. This is a chronic inflammation of the bronchi which is associated with destruction of the wall and permanent dilatation. In most cases, repeated episodes of infection and obstruction lead to a progressive destruction of the normal elastic and the muscular components of the airway wall. Obstruction may be due to foreign bodies in your bronchi, tumor, structural abnormalities, or stasis of secretions, perhaps related to ciliary malfunction or CF or the cystic fibrosis. In this micrograph, two abnormal bronchi are seen, each with a lumen filled with pus, letter P. The wall of each affected bronchus is formed of fibrovascular granulation tissue in letter G, in which there is a heavy infiltrate of dark staining cells just visible at this magnification. These cells are a mixture of plasma cells and neurolymphocytes. This is a common example of a chronic abscess in the pilonidal sinus. In this condition, a chronic subcutaneous abscess forms, most commonly seen in the sacrococcygeal area. Hair shafts in H, derived from locally destroyed follicles and shed body hair, are present in the abscess and act as a focus for chronic inflammation. In this micrograph, you note that the subcutaneous abscess cavity in letter A, the wall of which is formed by the granulation tissue in letter G, is heavily infiltrated by lymphocytes and plasma cells. There is surrounding fibrosis, or letter F, in the dermis as a result of previous attempts at fibrous repair. This micrograph is showing you an idiopathic pulmonary fibrosis or your cryptogenic fibrosing alveolitis, which is a good example of a chronic inflammatory condition that in its earliest phases has a chronic inflammatory infiltrate. At this early stage, it may be called interstitial pneumonitis or usual interstitial pneumonia, where an unknown damaging agent repeatedly triggers the inflammation of your alveolar walls, which lead to extensive fibrosis as part of the healing process. Idiopathic pulmonary fibrosis is one of a group of disorders known as interstitial pneumonias. In addition, there is damage to the alveolar lining cells and they are replaced by hyperplastic or regenerating type 2 pneumocytes. In this figure, the inflammatory infiltrate of lymphocytes and plasma cells is readily seen, as well as your type 2 pneumocyte hyperplasia in letter P, shown in the next B image. This is the organ transplantation which introduces your non-self antigens into the recipient. Specifically, the HLA antigens or your human leukocyte antigens of the donor are rarely identical to those of the recipient, except in the case of transplantation of organs between identical twins. The HLA antigens of the donor excite both antibody and cell-mediated immune responses in the recipient in an attempt to rid of the body of this foreign material by killing your donor cells. In this image, there is an infiltrate of lymphocytes, most of which are T cells, in the interstitium or letter I of your kidney. The tubules are atrophic and widely separated. Your L or lymphocytes can be seen within the tubular basement membrane between the tubular epithelial cells. We call it the inflammation or tubulitis. This is your giant cells in letter A, foreign body giant cell in high power, and letter B, Langhans giant cell in high power. As described in the introduction, your multinucleate giant cells are formed by the fusion of your epithelioid macrophage, and they are highly characteristic, though not universal, feature of your chronic granulomatous inflammation. These micrographs illustrate typical appearances of your giant cells. In this letter A, which is a good example of a foreign body type giant cell, which is characterized by a central group of nuclei similar to those seen in adjacent epithelioid macrophage in letter E. The second important form of giant cell is the Langhans giant cell, which is said to be a characteristic of tuberculosis. In letter B, the multiple nuclei of Langhans giant cells are arranged in a horseshoe formation around the periphery. Again, epithelioid macrophages in E are seen in the surrounding tissues. Letter A is an enlarged alveolar space. Letter E is your epithelioid macrophage. Letter F is your fibrous tissue. Letter I is your interstitium. Letter L is your lymphocytes. And letter P is your type 2 pneumocyte hyperplasia. This is sarcoidosis. Sarcoidosis, letter A in your lymph node in medium power. And letter B is your sarcoid granulomas in high power. Sarcoidosis is a chronic granulomatous disease of unknown etiology, characterized by the formation of your multiple discrete granulomas in many tissues. In marked distinction to classic tuberculosis granulomas, those of sarcoidosis do not typically undergo central caseous necrosis, although small foci of necrosis may be seen in your large granulomas. In letter A, it illustrates a part of a typical lymph node. Note that the scattered non-caseating granulomas in letter G, since there is no central mass of caseation. The sarcoid granuloma differs from the tuberculosis granuloma by having much a broader zone of your epithelioid macrophages. Letter B shows a typical sarcoid granuloma at higher magnification. Note that the epithelioid macrophage in letter M, there are multinucleate giant cells which are a feature of most of the granulomas. The cytoplasm of sarcoid giant cells may contain inclusion bodies of two types: eosinophilic star-shaped asteroid bodies in letter A, or small laminated calcified concretions called Schumann bodies in letter S. This is a foreign body reaction in letter A, foreign body granuloma in low power. In letter B, this is a giant cell with inclusion in high power. At low magnification in letter A, it shows a plant material in letter P derived from feces that has become embedded in the wall of the colon in a patient with diverticulitis. Diverticular disease is a condition where the mucosa of the bowel herniates through the muscular wall, forming a pouch or diverticulum in which fecal material may become impacted, leading to inflammation and sometimes perforation. The pale, incompletely digested plant material is surrounded by aggregates of foreign body giant cells in letter F and epithelioid macrophage in letter M, as well as other inflammatory cells. At high power in letter B, a fragment of plant material can easily be seen within the cytoplasm of a Langhans type giant cell. This is xanthogranulomatous inflammation and lipogranuloma. In letter A, xanthogranulomatous cholecystitis in medium power. In letter B is lipogranuloma in fat necrosis in high power. Xanthogranulomatous inflammation is a rare condition most often seen in the kidney or the gallbladder. Although rare, these are important lesions as they may form a mass that can be mistaken for a malignant tumor. In letter A shows a xanthogranulomatous inflammation in the gallbladder at medium power. Another much more common appearance is the accumulation of a lipid-laden macrophages in areas where fat is released from adipocytes, often in areas of fat necrosis. In letter B shows such an area where necrotic fat cells are easily identified by their lack of nuclei. Occasional lipogranulomas in letter L may be seen, consisting of a droplet of lipid surrounded by foamy macrophages. This is the summary of the first few slides. The type of chronic inflammation, their histological features, and there are some examples. Again, there are three types of chronic inflammation. Non-specific follows on from unresolved acute inflammation. There are also specific chronic inflammation, the non-granulomatous one, and specific chronic inflammation in granulomatous. And there are some examples of these diseases following the three types of chronic inflammation: chronic peptic ulcer, bronchiectasis, pilonidal sinus, ulcerative colitis, viral infections, idiopathic pulmonary fibrosis, cellular rejection of transplanted kidney, and lichen planus. sarcoidosis, foreign-body giant cell reaction, tuberculosis, leprosy, and Crohn's disease. This is the body of the stomach in H&E low power. These micrographs illustrates the body of the stomach in the non-distended state. The mucosa in M is thrown into prominent folds or rugae and consisting of gastric glands that extend from the level of the muscularis mucosa in MM to open into the stomach lumen via the gastric pits or the foveolae, GP. The muscularis propria comprises the inner circular C and outer longitudinal, letter L, layers, but the inner circular layer is reinforced by a further inner oblique layer, or letter O. The submucosa SM is relatively loose and distensible, as you've seen here, and contains larger blood vessels. The serosal layer, which covers the peritoneal surface, is thin and barely visible at this magnification. The adipose tissue of the lesser and greater omentum is attached along the lesser and greater curvature of your stomach. This is not illustrated here. Lymph nodes and large blood vessels lie within these omental fatty tissue. This is chronic peptic ulcer. A partial gastrectomy was performed because of hematemesis. There was a bleeding artery in the base of the ulcer, as is shown in this image. Bronchiectasis. There is a left lower lobectomy was performed for chronic bronchiectasis. The patient had recurrent attacks of pneumonia since the age of 1. The bronchial tubes are extremely dilated, their walls are thickened and fibrotic and ribbing, and they can be seen along the mucosal surface of some of them. The adjacent lung has been almost completely destroyed. Surgical treatment of your bronchiectasis is only useful when the condition is localized to one segment of the lung. Bronchiectasis of this severity is also seen in patients with cystic fibrosis. It can be prevented by aggressive medical and physiotherapy treatment of pneumonia in children. This is tertiary segmental bronchus elastic van Giessen in medium power. And as your bronchi diminish in diameter, the structure progressively changes to resemble more closely that of large bronchioles. The epithelium, just visible in this image, is seen here, is tall and columnar with little pseudostratification. Goblet cell numbers are greatly diminished. The lamina propria is thin, elastic, and completely encircled by smooth muscle in letter M, which is disposed in a spiral manner. This arrangement permits contraction of the bronchi in both length and diameter during expiration. Seromucinous glands in letter G are sparse in the submucosa. These glands are rarely found within smaller airways. The cartilage framework in letter C is reduced to a few irregular plates. Cartilage does not usually extend beyond tertiary bronchi. You note also that the submucosa in letter SM merges with the surrounding adventitia and then with the long parenchyma. There are small aggregates of lymphocytes in letter L as a part of the mucosa-associated lymphoid tissue, your MALT, which are seen in the adventitia. This is the terminal portion of the respiratory tree in H&E low power. Terminal bronchioles, letter T, are the smallest diameter passages of the purely conducting portion of the respiratory tree. Beyond this, branches become increasingly involved in gaseous exchange. Each terminal bronchiole divides to form short, thinner walled branches called respiratory bronchioles, which contain a small number of single alveoli, letter A, in their walls. The epithelium of the respiratory bronchioles is devoid of goblet cells and largely consists of ciliated cuboidal cells and smaller numbers of non-ciliated cells called clara cells. In the most distal part of this respiratory bronchioles, clara cells become the predominant cell type. Clara cells have three functions. First is they produce one of the components of surfactants. They act as stem cells Example, they are able to divide, differentiate, and replace other damaged cell types. And lastly, they contain enzyme systems which can detoxify noxious substances. This is a honeycomb lung, which the patient had interstitial pulmonary fibrosis, the exact cause of which was not determined. This is the lymph node structure and the vascular organization. Take a look at this because we will be reviewing this in the immune system disorders and your immune system tissues. Even in the hematopoietic and your immune system lecture presentation. This is in low power. The lymph nodes are small, bean-shaped organs which are situated in the cores of lymphatic vessels, such as your lymph draining back to the bloodstream. First passes through one or more lymph nodes. Inactive nodes are only a few millimeters long but may increase greatly in size when mounting an active immunological response. Most of your lymph nodes in the body show some degree of reactive change in response to the constant barrage of antigen to which they are exposed. This is just a diagram. You see here the afferent lymphatic, the valve, the cortex, your medullary sinuses, the medullary cord, the trabecula, the capsule, the subcapsular sinus, your lymphoid follicle with your germinal center, your afferent lymphatic. This is your vein and your artery for the blood supply. The gallbladder in letter A is in H and E, low power. The intrahepatic bile collecting system merges to form your right and left hepatic ducts which join in creating a single large duct, the common hepatic duct. On leaving the liver, this is joined by the cystic duct which drains the gallbladder. The common bile duct, so formed, joins the pancreatic duct to form the short ampulla of Vater before entering the duodenum. The bile draining down the common hepatic duct is shunted into the gallbladder where it is stored and concentrated. In this micrograph, it shows the wall of the gallbladder in the non-distented state in which the mucosa is thrown up into many folds. At this higher magnification in this micrograph in letter B, the simple epithelial lining of the gallbladder is seen to consist of a very tall columnar cells with basally located nuclei. Numerous short, irregular microvilli are accounted for the unevenness of the laminal surface. The lining cells concentrate bile 5 to 10-fold by an active process. The resulting water will pass to the lymphatics in the lamina propria in letter LP. In letter C, it illustrates the wall of your cystic duct which is formed into a twisted mucosa covered fold in letter F known as the spiral valve of Heister. The flow of bile and pancreatic juice into the duodenum is controlled by the complex arrangement of smooth muscle known as the sphincter of Oddi. The components of the structure include your choledochal sphincter at the distal end of the common bile duct, the pancreatic sphincter at the end of the pancreatic duct, and the meshwork of muscle fibers around the ampulla. The arrangement controls the flow of bile and pancreatic juices into the duodenum, and at the same time, it prevents reflux of bile and pancreatic juice into the wrong parts of the duct system. When the choledochal sphincter is closed, the bile is directed into the gallbladder where it is concentrated. This is xanthelomatous pleonephritis, which the kidney is open to show the features of your acute pyelonephritis, together with large areas of hemorrhage and lipid accumulation. These features occur in a small percentage of cases of pyelonephritis, but they do not appear to have any special significance. To sum it up, this is the chronic inflammation as a response to a prolonged duration, usually weeks or months, and in which inflammation, tissue injury, attempts at repair and coexisting in varying combination. We have causes: persistent infections, which is promoting delayed type hypersensitivity, granulomatous reaction, and some chronic inflammations evolved from acute inflammations. hypersensitivity reactions like autoimmune diseases, allergic reactions that produce your antigen-antibody complex reactions. Prolonged exposure to potentially toxic agents, either exogenous such as your silica, causing pulmonary silicosis, or endogenous such as lipids causing atherosclerosis. The morphological features include with mononuclear cells in their infiltration, macrophages, lymphocytes, and your plasma cells, and their tissue destruction and attempts at healing. And there are macrophages, which are the dominant cells in most of the chronic inflammatory reaction, which secrete cytokines and growth factors. They are activated using two different pathways: classical activated macrophage in M1 and your alternatively activated macrophage in M2. Their functions of macrophage: ingesting and eliminating microbes in dead tissues, secreting mediators of inflammation. They display the antigens to T lymphocytes and respond to signals from T cells, where they initiate the process of tissue repair. We have also lymphocytes, as the microbes and other environmental agents activate your T and P lymphocytes, which amplify and propagate chronic inflammation. By their virtue of ability to secrete cytokines, CD4 plus T lymphocytes promote inflammation and influence the nature of the inflammatory reaction. And we have your TH cells, and shown here producing different molecules. And lastly, we have your other cells in chronic inflammation, such as your eosinophils, which are abundant in immune reactions and that are mediated by immunoglobulin E and in parasitic infections. Your mast cells, which express on their surface the receptor FcRI that binds the Fc portion of your immunoglobulin E antibody. And lastly, the basophils. And that's all for this presentation, and the next presentation will be dysplasia and neoplasia for your histopathology laboratory series here on YouTube. Thank you so much for watching.